afternoon, everyone. Thank you for joining our webinar today from the National Council of Urban Indian Health. We'll get started, but first, while we're waiting, if you could please provide your name and organization in the chat box so that we just know who's on the call, that would be really helpful for us. We are getting started, and I just wanted to mention that your lines are muted, but if you would like to write anything into the chat box as far as a question is concerned, please feel free to do that. So I'm here at the National Council of Urban Indian Health, and I would like to thank you again for joining us for today's webinar titled Indigenous Communities Across the Americas Looking at Suicide Prevention. The National Council of Urban Indian Health is a membership-based organization that represents the 43 urban Indian health organizations across the nation that provide essential health and social services to American Indians and Alaska Natives living in urban settings. As I mentioned, all lines are currently muted. If you wish to ask a question, please place them in either the Q&A pod or the participant chat box in the lower part of your screen. We'll have time at the end for Q&A for your questions to be answered. Today, we're excited to have with us Ms. Deborah Castro, who is the Senior Mental Health Policy Specialist at the Pan American Health Organization, World Health Organization, with more than 25 years of international experience in Europe, the Caribbean, and Latin America. She's been implementing and advising governments on national policies related to mental health systems over that time. She's a strong advocate for the rights of people with mental health issues. Ms. Castro obtained her Master's of Science in Psychology from the Universidad Nacional de La Plata in Argentina and her Master's of Science in Public Health at the London School of Hygiene and Tropical Medicine in the United Kingdom. In 2015, she became the Unit Chief for Mental Health and Substance Use at PAHO. So we're happy to have her today with us to present on this really exciting topic. In honor of National Indigenous Peoples Day that was held on last week. The presentation slides are available in the presentation slides and handout pod if you'd like to download those for your review later on. We'll also be sending out some follow-up emails that will contain the presentation PowerPoint as well. We are recording this presentation and it will be archived on the NCUI website. So at this point, I would like to start with some opening questions for discussion. And the first one is, if you could answer by selecting yes or no, do you have a background working in mental health? And see if you all have started to actually select your choices. Okay, so I think possibly everyone might have seen or had an opportunity. So you can see here that we had approximately 66%, 63.6% said yes, whereas 36.3% said no, that they don't have a background working in mental health. So we have a good number of people that have some experience in mental health and behavioral health. For our second poll question, which is coming up right now, the question is an open-ended question, so if you could take some time actually to fill this in. And it's asking us, what are the most common mental health-related issues in the community? If you could just type your answer in, just so we can see what you might have as thoughts. So we have depression, anxiety, suicide. Thank you for responding. So all of those answers: suicide, depression, mental illness, untreated mental illness, are areas, and substance abuse, are all areas that those that are on the webinar seem to be dealing with in their communities. Thank you for taking our poll. With that, I would like to turn it over to Deborah for her presentation. Deborah, you have the floor. Just make sure you take off the mute.
So thank you very much, Kimberly, and thank you, everybody, for being there and for giving us basic information about who you are, or if not who you are, what do you know, or what's your concern, what are your concerns around the topics we are about to discuss. Kimberly already introduced me. What we could add to that is that as of last week, I'm not anymore the unit chief of mental health and substance use in PAHO because I became the director of the same department in WHO. So I'm moving from the regional office of the World Health Organization to the global office of the World Health Organization, and to be in charge of mental health and substance use issues. And interestingly enough, in my first meeting, still sitting here, but already on that job, it was a meeting in New Zealand, and I discussed the issue of indigenous communities in the region, in this region, who are probably in need of some attention when we talk about mental health. And you have to keep in mind that whatever I will say to you, it is on one hand general, not always focusing specifically on indigenous communities, and on the other hand, it is based on some information and some work or collaboration that we have in different countries of the region. So it's not US-based, and so you may have way more information than I do, perhaps, on some issues. Having said that, I hope you are used with my accent by now, but if not, you will be hopefully in a few minutes. So I'm going to move ahead. And the idea today is to give an overview of, a presentation of a background of what is the Pan American Health Organization, a bit of the mental health and suicide prevention initiatives and current situation in the region, something about indigenous health, again, in the region of the Americas, and then some brief information on what we have done in specifically regional meetings that we had on these topics, and some projects that we have been promoting or trying to implement in different countries, actually. And then the way forward that will get also your input, hopefully. So as I said before, the Pan American Health Organization is the regional office for the Americas of the World Health Organization. And for those of you who do not know that, the World Health Organization is the health agency of the United Nations. The United Nations, composed by member states, has different areas of work. Health has been, let's say, delegated to this organization. And when the WHO was established in 1948, PAHO was already existing because it was created in 1902 and became gradually a region and the first international public health agency until it became, as I said, part of the WHO. And our work is to engage and provide support, technical cooperation to the countries in the region to fight communicable and non-communicable diseases, to strengthen health systems, and to also respond to emergencies and disasters. We do work with 52 countries and territories. We work also with the UK and territories, and the French departments, etc., but also, of course, all the countries of the region, depending the country, how strong or how present we are going to be and how the technical cooperation is going to be. I'm saying this because then when we talk about the US and Canada, the collaboration is different than if we talk of Haiti, to name one. So I'm sure you can understand by now what am I referring to with this difference. Our mission, vision, mission, and values are there, and you can see that the vision is that all the peoples of the Americas enjoy optimal health and contribute to the well-being of their families and communities. And the mission, as I said, is the collaboration among member states and different partners to get to that vision. The values are equity, excellence, solidarity, respect, and integrity. And when I'm saying then that we want, or we are working in order to ensure that all the peoples of America, that means all, including those that may be in more disadvantaged conditions or in conditions of vulnerability. And in most of the countries of the region, it may also include then in that group of disadvantaged conditions or conditions of vulnerability, indigenous communities. That is the case in several countries of the region, and perhaps also in some regions here in the US as well, definitely in other countries. We have then every 5 years a strategic plan that is defined between all those member states, all those countries and territories, and us, the organization, to identify priorities and what are the main issues we see all together in a collaborative way, which are the ones we identify as the main issues, and what are we going to do with those issues. And you can see that there are some 4 cross-cutting issues on gender equity, human rights, and ethnicity. And I'm mentioning this here because this is, when you look at the global agenda, ethnicity is not always there. For us in this region, ethnicity is a cross-cutting issue, is something that we are invited, I would say, but also somehow sometimes even pushed to look at. It's not something that we can afford to ignore. And we are right now working, for example, on the development of the strategic plan 2020-2025. So that's how we move with our planning. And then within that context and that framework, we have specific plans of technical cooperation that are defined every 2 years. So we are now running the biennium 18-19. And I'm going to go back to that and explain later on when I will describe some of the projects that we were done as part of a collaborative project in some biennium with the US or with Canada specifically and Chile specifically related to indigenous and mental wellness, perhaps, if we can call it somehow. I hope you are following up properly. If not, please let me know. I can repeat, slow down, or ask translation from my broken English to a proper one. So we have we use this slide perhaps as an example of, okay, well, let's talk about mental health in the Americas. This is a campaign I've seen. This is a campaign that we had a couple of years ago. That was the World Health Day last year, actually. It's World Health Day dedicated to depression, and so that was the slogan. Let's talk, and this is what we are going to do now. We will talk about mental health. And without going into the details, I don't want to bother you with this slide and the level of details. But what I am representing here, you have a set of columns I don't know if you see the course. Yes, you do, I think, because I was seeing it before. The set of columns that is the Americas, and then the other one that is Latin America and is missing the Caribbean, because frequently we divide the analysis between the entire region and the rest of the region, excluding the U.S. and Canada, right, because of the difference. So when looking at the Americas, and even more recent studies here in the U.S. specifically, we know that if we have all those prevalences, the number of people with some condition over the last year, for example, or in a lifetime measure, we start adding and we get a very high percentage. It's been said globally that 1 in 4 persons will develop a mental health issue at some point in their life, or in our life, we could say. I recall having seen a document from the U.S. talking about 1 in 5 adults, for example, with a mental health condition. So the prevalence is very high. We are talking about, again, 1 in 4, 1 in 5, between 20 and 25% when we look at the lifetime. So that's huge. But we also see this column, the third of the first set, treatment gap, and is the number of people with severe mental health conditions that do not receive treatment. That was done studying, again, the previous year, and we see that looking at the US, at the whole region, we have let's go to a common one, major depression, 55%, some alcohol, 8%, anxiety, 67%, of people with those conditions that do not receive any treatment. And when we look at this information globally, we have that in the developed world, in the richest countries, the percentage of people that do not receive treatment is between 35 and 50%, which is huge if you compare to other conditions that are not left untreated or are not left ignored, as it happens in mental health. My predecessor at the World Health Organization used to say that when we talk about mental health, we are all developing countries. Meaning that we are all really behind where we should be. When we look, I'm sorry, I go back a bit to that. When we look at the situation in the rest of the region, excluding the US and Canada, of course, the situation is even worse. Those are the last 3 columns. So another way we have to look at the problem is the burden of disease. And it's the disability-adjusted life years, the years that are lost due to disability. And we have here the colors that indicate that the communicable diseases, maternal and child health conditions that were those that used to kill people globally are becoming, in our region, less relevant, less present, and more space is occupied by non-communicable diseases, that is the dark blue, diabetes, cerebrovascular conditions, cancer, respiratory conditions, and then the light blue is the mental health, neurological, and substance use conditions, which means that nearly 1/3, or in some cases even a bit more perhaps, of the whole illnesses that contribute to lose years of life due to the disability cause are those that are our interest right now, right? We have here the fourth, starting from the back, is the U.S., and you see the green that is injuries, and then very small number, of course, of people with, sorry, this is not people, but it's the years lost due to disability. Is communicable diseases is very, very small, and then everything else is non-communicable diseases and mental health. So it's a big presence that is becoming more and more known, and that still, as I said before, is not necessarily the relevance is not necessarily fully recognized when we talk about solutions or commitments from member states, from countries, from those that take care of health issues, right? Then related to this, we have the suicide mortality in the Americas as a very important problem, where we are estimating. It was interesting because until a few months ago, we kept using a figure that was from previous reports, where we were told that 65,000 people will die by suicide each year in the Americas. The most recent report is talking of 97-something thousand people dying by suicide each year. And you have, I'm sure you have seen or heard the recent report that was issued here in the U.S., where the figures are really scary in terms of the numbers increasing, but also the age of people dying by suicide. And it's in the Americas the third leading cause of death in people between 20 and 24. And as it happens globally, it also here in the Americas, it is higher in men than women, but the suicide attempts are more frequent in women. And then the 70 and above age group has the highest rate of suicide. And what you see here are the different logos of the campaign for the World Suicide Prevention Day that took place a month and a bit ago. When we look at the suicide death rates, as I was showing, the age, it is definitely the above 75 is increasing, but is, I think, of big concern. Definitely it is for me, is the youth, young populations that even younger than before are dying by suicide right now. We had recently some studies. We have some, as I mentioned before, some priorities established in the region, and so we've been monitoring a bit the situation, and we see that it is relatively stable with a slight increase in the numbers at the regional level. In the red in the middle is the line that is the whole Americas, but look where North America is. This is the US and Canada. It's way higher than the rest of the region. There are a couple of things here that we have to keep in mind, and one is that the recording system is better. So even this slight increase that we see over the last couple of years, I wouldn't be sure to say that this is a real increase, or perhaps it is an increase due to some efforts, ongoing efforts to improve the recording system. But still, what we can tell is that the trend is going up for one reason or the other, so we need to monitor that. And when we were looking at some examples of countries and the youth in particular, it's really worrisome. So it's really a concern. You can see here examples of countries and how is the trend going. We do have some work in progress, but I think that is not enough, probably. Okay, so in this context of a very sad or situation that raised concern, we have developed a plan of actions on mental health. And this is the strategy that countries use to commit their attention in the first place, but then they support to specific topics. So at some point it was understood that mental health is a priority that they should pay attention to, and in 2013, for the first time in the history, the World Health Organization had 194 countries agreeing that mental health is a priority and that there are some actions that should be taking place in each one of the countries. And as you can imagine, between countries there is a wide difference in every aspect probably. Nevertheless, the agreement is that there are some basic actions that then are targeting each country differently, but basic actions that should take place everywhere. And in the same context, at the regional level here in the Pan American Health Organization, we had already an action plan on mental health from 2009, and it was updated then in 2014, was drafted and then approved, and to follow up, to be aligned with the global one that was issued, as I mentioned before. So both plans have similar priorities and areas of work that are those listed there, leadership and governance. We want to be sure that at the highest level in the health sector, there are those positions to advocate properly for the implementation of mental health issues as agreed in the plan. And then we promote the development, establishment of community-based mental health services. Examples in many countries are of old-fashioned mental institutions where people are still locked up, but also countries where the institutions were closed, but not enough services were developed. And so people with mental health conditions may end up in prison instead of in a health facility. And that is something that you may be familiar with, because it's one example of what happened here in the U.S. in some regions, in some contexts. And then the third area is promotion and prevention, and here is where we focus also on child and adolescent health, mental health, and then suicide prevention in particular, and then information systems, evidence, and research, because with the exception, of course, of the U.S. and Canada, the rest of the countries are really behind on these issues, with some exceptions again, but still mostly behind. One key strategy that we promote to integrate mental health in the health sector, and particularly at the first level of care, is this mhGap, WHO mhGap. And then let me drink just a bit, so sorry. Okay, so the mhGap is a program that was developed in 2008, and guidelines were, and the GAP, you can see that the name is Global Action Program, but the GAP stands for the treatment gap we talked about before, and the guidelines were developed in 2010 and were updated in 2016. And the guidelines are guidelines for the intervention of what were considered and are still considered the key issues that are present in more present in global level in terms of prevalence, as we said before, also in terms of the burden that they imply, but also when conditions that we acknowledge that the existence of effective, cost-effective treatments available. So we are not saying this is important and we don't know what to do with that, but we are saying this is important and we know what to do with that. And the guidelines were developed to train non-specialized professionals. So it was keeping in mind settings where there were a limited number of specialized professionals. And by specialized, I of course mean psychiatrists, psychologists, specialized social workers, etc., nurses, etc., that may have the specialization. For those contexts where that specialization is not, then this is what we are proposing. And the modules are on depression, psychosis, epilepsy, dementia, alcohol, substance use, suicide, child and adolescents, and you can see then that there are mental health conditions, substance use conditions, and also 2 main neurological conditions. And I'm going into this detail because we are going to go back to that at some point later. So one of the issues that we are then, the strategy that we are using, and one of the issues that we are promoting, and the mhGap is a tool for that, is the integration of mental health in the health system in general. And this year we celebrated the World Health Day around universal health, which means that if we talk about universal health, we talk about universal meaning for everybody, without discrimination, leaving no one behind, and then also including their all health-related issues, and mental health or mental wellness is part of that. There is the definition of the World Health Organization in its constitution in 1948, as I said, where it says, you may have seen that sometime, that says health is not merely the absence of a disease, it's a physical, mental, and social wellness. So mental health is part of health, and it should then be considered as part of any universal health approach. We are then working now on some issues that are more specifically related to suicide prevention, and one of the exercises that we have been doing recently is to develop safe messaging for suicide prevention in collaboration with Canada, and as part of the biannual collaboration that I mentioned before that we established with countries. So in the context of this developed with Canada, we are coming up with a regional tool for safe messaging that will then be adapted at country or local levels. And you see here in the picture that there is a colleague from SAMHSA, from the Substance Abuse and Mental Health Agency here in the U.S., and the others are from Latin America and Caribbean countries, where we are trying to come up with a general tool, a regional one, that can be then, as I said, adapted according to the needs. The issue of suicide being linked to youth is something that, of course, is of concern, and so the use of tools that are accessible for youth is one strategy that we are trying to promote and to develop. And then the other strategy that we have recently developed, a tool, is a virtual suicide prevention course that is, again, based on the mhGap that I showed before, and developed to be accessible through a virtual platform that we have to strengthen the capacity of primary healthcare providers or healthcare providers, again, of non-specialized in mental health, to detect, access, and manage and provide follow-up, actually, to people with suicidal conduct. I didn't say it before when presenting the mhGap. What we are looking for is not just to strengthen capacities of general practitioners, physicians, nurses, or the communities to identify the problem, but also to be able to manage it at their level and to refer to a specialist if when needed. But fundamentally, we are looking at reducing that treatment gap or that gap of care in general by increasing the number of people capable of answering to the needs of people with these issues. Then I'm going to tell you a bit about what are we doing or have done in the region, and we will present a bit about indigenous communities in the Americas. As I mentioned before, we have ethnicity as a cross-cutting principle in this region, which means that we have a person that works only on indigenous health across the region, from Canada to all the countries, and you have there a table with some information in mostly Latin American countries of numbers of indigenous and the percentage of indigenous people in the total population. And some of the countries is even more than half or nearly half of the population. And nevertheless, it's not always considered as, I wouldn't say as a priority, but as relevant as those that may be managing the health portfolio or agenda. So we see, if we talk in general about health, indigenous health in the region, I'm not sure we are saying it before now, I don't recall the slide, but we, last year, a policy paper on indigenous and ethnicity in general was approved by member states, again, ensuring that there is going to be the required effort to answer to the needs of those communities on different issues that the communities themselves consider relevant. And in general, when we talk about health, then we have higher rates of maternal and infant mortality, child malnutrition, communicable diseases, HIV/AIDS, malaria are TB, tuberculosis, these are all very frequent conditions that are encountered in the communities in the region, violence, alcohol and substance use, and depression. And then we do not have enough information. The systems that are sometimes the health systems and the data collection that may not be the best available in the region. It is even of lower quality or poorer in terms of information when we talk about indigenous communities. And the barriers to accessing health services in general are related to geographic, economic barriers, but also discrimination and challenges around language and access to information. When we were looking at, this is from a couple of years ago, we were looking at this specific issue, and also more recently actually, and we don't know, and in the issue of suicide in the community, when we started to move ourselves in this area, in this around this subject several years ago, we were surprised perhaps by the similarity in among communities in different countries in terms of a very high rate of suicide when compared to the rest of the country. And this you can find from Canada to several countries of the region. And here we have some limited data, but because not every country and not definitely at national level has this information. We have here some data in Ecuador that suicide rate in indigenous communities is twice the one of non-indigenous population and then it's tenfold higher among indigenous youth between 15 and 19, which is terrible. And in Colombia, the rate of suicide among one specific community, Embera, is nearly 250 per 100,000 compared to the national rate of 4 per 4.5. In Peru, the parents in a study estimated that there are 1 or 2 suicide attempts per month in each community. And you know, I'm sure perhaps you can share afterwards some information that you may have from the U.S. and you may have read now and then information that is coming from Canada with those rates or even situations at community level that are really of high concern. The social determinants of indigenous health and mental health, I feel a bit ashamed to say this to you because you do know this way better than I do. But that's something else that was a surprise from some of us when we encountered so common issues between the most distant, the two extremes of the continent, that may be the north of Canada and the south of Chile. They both communities, when talking to each other, presented common challenges. And here we have some: the historical trauma, the colonialism, the lack of land rights, political and social marginalization, racism and discrimination, unemployment, fewer educational opportunities, and poverty. Of course, the living conditions and status and all political issues will change from country to country, but still, I don't know, when talking about the land and the land rights in the north of Canada, the problem once was around whales and the whale industry, and in the south of Chile where the forest, but there was the forest and the industry related to that, but still the consequences were very similar. But again, I'm sure you have plenty of examples way richer than this. So we have, that's what I mentioned before. Last year then was approved a policy of the ethnicity and health. And again, as I mentioned when talking about the mental health plan, this is something that means that all countries and territories in this region agreed that this is a priority and that we together need to do something on this, and that we, the technical people, should support countries in these issues. And so the policy promotes an intercultural approach to health to eliminate health inequities among indigenous peoples, Afro-descendants, Roma, and members of other ethnic groups as applicable to the national context. This is then general on ethnicity, not exclusively on indigenous communities, because there are other groups that may have or may go or may have gone through similar challenges. So when we began our work in this field, trying to promote, to learn more and to promote some exchange among communities in the region, we had a couple of meetings, and then at some point in actually started 2013, 2014, and then it went to 15, 16. The years there are a bit wrong. But for 4 years, actually, we had some funding, small funding, just really to give you an idea, like $50,000 every 2 years for in two opportunities. So really small funding, but to promote the exchange, initially planned to be done between, as I mentioned before, the north of Canada, the Nunavut, and the south of Chile, particularly the Mapuche community there. And so we had a series of workshops in Chile and in Nunavut, and we invited other countries to participate, and the idea was to exchange experiences then on indigenous mental health promotion and suicide prevention. A bit my the aim of this has been, and is still now, I am aware of a lot of interesting, useful, and rich experiences developed by the communities themselves and implemented by the communities that have been useful, but that may not be known by other communities, or may not have the possibility to continue its implementation, etc. So this was this exchange has been aiming at that. Let's see what's going on, learn from each other, and see what we can do to support the process. And that was the first time actually that we discussed in Canada, in Nunavut, at a meeting there, the possibility to adapt the mhGap to their reality. And what I didn't mention before is that the mhGap has a version that was developed for community workers, so for non-health personnel. Let me drink something. Sorry. Okay, and so the level of information, but also it's not medical, but still it maintains the idea of identifying a person that might be suffering from being sad instead of talking about depression, or that may be confused, and we don't talk about dementia, etc., but follows the same criteria. And so the first exercise was done in Nunavut a few years ago. Then continuing with this collaboration, we had, and then Kimberly and some other colleagues here from the U.S. also joined a 2-day workshop in Montreal, Canada, where we define some panels to examine the models of wellness, indigenous models of wellness on one hand, and indigenous health systems approach to suicide prevention. How can we give the opportunity to participants to express, to share what they have been doing, and then again see how we can support that process in the future. And here you have a picture of participants. That was one of the nicest meetings I have ever been because of the variety of people around the room, and again the same feeling that everybody is different, but everybody is not so different at the same time. We all have similar issues and similar challenges and similar strengths and capacities as well. We have this booklet that we can share with you if interested. And these are examples of what has been presented, the different models of well-being. So you may be familiar with the First Nations Mental Wellness Continuum that was presented, but then also here some from Lakota people that was also introduced, and then the Mapuche definition of their model as examples of different understandings to what surrounds us and what may be equilibrium and what may break an equilibrium and what to do with that. And so here are some Indigenous-led interventions, what to do to restore perhaps some equilibrium. And if I'm not wrong, this is also from the north of Canada, the fishnet model, and the next one is from Colombia, and this last one was traditional, not traditional, mixed Western setting, is from Panama, if I recall properly. So the examples, the discussions were around gatekeepers, cultural revival, using the traditional knowledge, youth empowerment, a lot of rich experiences that were shared, and some with really very stimulating results. And the other thing that was briefly presented there is something that we did again with Kimberly and the team, and perhaps some of you, I don't know, that was the exercise of the mhGap adaptation of the community workers tool that I mentioned before, that we discussed initially in Nunavut, and then we had some opportunity to explore the feasibility and the sense of the adaptation here with some communities in the U.S. and the team convened a group of partners to create this advisory council, and then there was a survey, and then an adaptation, and then we had a one-day training here. That's the picture, not the best picture to see faces, but this is here in an office next to where I'm sitting right now. The training was then, the adapted version was then run for one day to representatives from 8 communities from Native American communities, and this was led by the colleagues from the National Council of Urban Indian Health and PAHO Consultant. And then 2 or 3 weeks ago, a similar exercise took place in one community in Colombia. We ran a very similar exercise with the communities there, and again the interest and the positive feedback was common. So, lessons learned, the way forward. I think that we need to be sure that it's not, but we are promoting, let's say, we need to continue promoting the empowerment of communities, indigenous communities that are ethnically and geographically diverse, but not necessarily so far from each other, by exchange that cultural knowledge around common mental health issues. I got a bit distracted because I was thinking I went to Nunavut with a representative from the south of Chile. So he flew, I don't know, we said I think around, I don't remember how many thousands of miles from the south of Chile all the way to Nunavut. It took him like 3 days to get there. And on the way back, I met him there. I didn't know him, but on the way back, we spent some time in one of the airports, the connections, Ottawa or somewhere else. And I remember how he was really surprised and couldn't stop telling me, giving me examples of things that were similar between the people from the communities he talked to in Nunavut and his own community. Practices, cultural issues that were exactly the same, no matter how far one community was from the other. So that's why we insist that the exchange is needed and can be really useful. And then perhaps the need for an accessible platform to share those experiences. There are some platforms available, but not always. I mean, I'm familiar with a couple of them that are all country-based, or definitely there is one that is only in English. So that's one of the concerns we have, how to make this available also for other languages and promote a kind of repository of experiences, but also promoting the possibility to not just to read an experience, but to have the main protagonist of such experience to share it with others and be able to help others getting there where they are. Then the importance of research directed at needs identified by the communities themselves, using indigenous approaches and indicators. This was something that is always discussed, and several community representatives complain that they don't want researchers to come get the data and leave. But also in the meantime, we know that there are more and more researchers from the same communities that have had the opportunity to move forward and are keen to go back and work with the communities. And so how can we somehow promote or facilitate, if any possibility, if there is any possibility, any of that. And then when we talk about mhGap, in particular, the adaptation process, we believe it is itself is equally or even more important than the material adapted. We have seen that then the changes are not so many, but the exercise of adaptation is what makes the process rich. And then there is a need for different things and follow-up. I hope, can you hear me? Because I'm receiving a call in the same phone I'm using. And even if I'm not answering, I want to be sure that I'm still there.
You're fine. I can hear you.
Okay, great, thanks. So, yeah, this is then the presentation, and just to finalize, I wanted to say that in order to continue with this kind of collaboration and promoting the exchange, etc., we have developed some potential collaboration with other regions of the world, particularly New Zealand and Australia, who have also very interesting experience in this field, and we are still trying to look for some funding to continue with this and to perhaps have some more bigger meetings. That would be fantastic to do. And so I stop here. I hope I managed the time as initially requested, and the floor is yours. Thank you.
Thank you, Deborah. Thank you so much for your presentation. It was definitely a lot of very interesting information on how the rest of the Americas have been challenged by suicide in Indigenous communities. I did want to open the floor that if there were any questions, if you could type those into the chat pod, or even comments. If you have any comments related to your own communities from what you've heard and what was presented, I'm sure that Deborah will be happy to hear from that as well. And while we wait for anything to come through on questions, just another reminder that the slides from this presentation are available for download in the lower right-hand corner of your screen if you would like to review those at a later point in time. And then also we are planning out our webinars for the year, so please watch out for any additional upcoming NCUE-sponsored webinars on our website. So we did receive a message thanking you for the presentation.
Yes, I see. Thank you.
Yeah. I guess lastly, before we get off of the line, we do ask that you take a few moments to provide feedback on today's webinar through our SurveyMonkey link that Mark is placing in the chat box right now. This can help further our webinar topics as well as provide the board with some feedback on her presentation as well. And you will also receive a follow-up email along with the recording of today's presentation within the next week or so. Laura, do you have any last comments or anything that you would like to say before we end the webinar?
No, I just want to thank you for this opportunity, and I really would like to learn more about what's going on, and keep me posted, and whatever you have to share, we can make sure that we will share with others in terms of experiences or practices that can be related to what we discussed today. So thank you from my side. That would be all.
Thank you, and congratulations on your new position. So,
thank you, Kim.
I did see someone typing, so I'm going to give it maybe 30 more seconds just to see if that comes through. maybe they were just trying to click on the link. If you do have any questions that come up after we close out, feel free to reach out to me, Kimberly Fowler. That's kfowler@nakui.org. And I'd be happy to pass those messages along to Deborah as well. So at this point, we're a little bit over the top of the hour. Thank you again for attending today's webinar, and take care and have a great day. Thank you all.
Thank you. Bye-bye.
Bye-bye.
Bye now.
So you want to